Okay, we have no disclosures. All right. Today I want to review a number of the current service trends in community psychiatry and also discuss how we've implemented some of these in our CPP program. So let's start with what is community psychiatry? Well, there are a couple of definitions that I like. The first by Brown describes it as a branch of psychiatry which emphasizes the integration of social and environmental factors with the biological and psychological components of mental health and mental illness. And this definition really demonstrates the breadth of what community psychiatry is meant to accomplish. This later definition by Drake is really a how-to definition, and it emphasizes the need to have services that are acceptable, accessible, patient-focused, evidence-based, and go beyond symptom management. So there have been a number, there have been a number of trends in community psychiatry that have emerged over the last few years. And today we're going to look at the development of e-mental health services, the increasing interest in recovery-oriented services, the expansion of services to include lifestyle interventions, and collaborative care, which, while not based in community psychiatry, is nonetheless a very important service delivery model. So what is e-mental health? Well, it's defined as the use of the internet and related technologies to deliver or enhance mental health services, examples being telepsychiatry or apps and texting that deliver programs online. And the great thing about e-mental health is its potential to allow more patients to access care. We know that in the US, the treatment gap, that's the difference between the proportion of patients who have a serious mental illness and those in treatment, is about 40.5%, which is high. We also know that ethnic and racial minorities are less likely to initiate treatment and more likely to drop out of treatment early. And additionally, 55% of counties in the US have no practicing psychiatrist. So increasing the use of e-mental health has the potential to greatly improve access for people. In 2018, the APA and the American Technological Association published updated guidelines on the best use of telepsychiatry, including clinical, technical, and administrative recommendations. Clinically, they stress that patients' suitability for telepsychiatry isn't a static function and should be reassessed regularly. They advised having a backup plan should technical issues arise, and they also discussed the importance of developing clear protocols to address any issues that should arise, such as a patient emergency. The onset of COVID-19 led to a rapid increase in the use of psychiatry, and a survey carried out by the APA in 2021 found that 59% of Americans were now happy to use telepsychiatry. And a recent survey at New York Presbyterian Hospital found that 73% of patients were somewhat or greatly satisfied with their telepsychiatry experience. Since the early 2000s, there's been an explosion in the number of apps and texting programs that have been developed in the area of psychiatry. We have apps to track mood, monitor symptoms, even deliver CBT online. And in the 2021 survey, 57% of Americans were open to using online support if in crisis. However, there are some concerns with the use of online programs, and there are very few examples where there's been a successful standardized implementation of programs. A meta-analysis by Ellis of online anxiety and depression programs found that only 10 of the 33 identified programs had used an implementation framework to evaluate the program. And a review by Torres of 293 commercially available apps for anxiety or depression found that just over half had referenced an evidence-based framework in their description. So there's a need for a lot more standardization and monitoring of these online programs. And as outlined by Smith in their recent review on digital mental health, we need more research in this area. Within community psychiatry, we've really adopted telepsychiatry as one of our service delivery models, And we've been involved in the development and assessment of a texting program to track early symptoms of relapse and schizophrenia. Prior to COVID-19, we used telepsychiatry occasionally in our ACT program. This was usually initiated by the ACT staff if they were visiting a patient who needed to be seen urgently. But with the onset of COVID-19, we rapidly pivoted to widespread use of telepsychiatry in the program. We developed protocols to address best practices. We procured equipment. We even used some philanthropy money to get phones for patients who didn't have phones that could do video visits. And we created or adjusted our templates so that would facilitate both the documentation and the billing of these visits. Just this month, as Jimmy mentioned, we published a paper led by Dr. Ackerman that describes our experience of implementing telepsychiatry in the program. Today, I'm going to talk about some of the published findings and also some more recent updates. We'll look at the impact of telepsychiatry on our volumes, our no-show rate, our hospitalization rate, and patient satisfaction. So, not surprisingly, over the first several months of COVID, the majority of our visits were virtual, with just patients who were getting injections, those in crisis, and those in our IOP program attending in person. For FY21, which was July 2020 to June 2021, we had our highest ever volume of visits at just over 19,000 visits. When we look at a breakdown of visits now, you can see that while we still do a lot of virtual visits, the number of in-person visits have increased significantly. Although our volumes are not as high as they were during that first year of the pandemic, we're still on track to have over 17,000 visits this year. As we emerged from COVID, it really provided us with an opportunity to reflect on how best to integrate telepsychiatry into the program. Obviously, sort of state and federal regulations kind of shape what we can do, but largely based on our own experience and from what we learned from our patients, we decided to conduct all our initial evaluations and the first several subsequent visits in person to help establish rapport. Thereafter, patients only need to attend in person every 3 to 6 months and do the rest of their visits virtually. Patients on injections and patients on IOP and patients in crisis attend in person. We have some patients who always prefer to attend in person, but for those who prefer virtual visits, most are fine attending in person every 3 to 6 months. In the paper, we looked at the overall no-show rate, which decreased significantly when we introduced telepsychiatry. And when we compared the no-show rate between virtual and in-person visits during that first year of the pandemic, we found there was a significantly lower at just over 14% for the virtual visits. When we look at our no-show rates now, we see that while there's still a significant difference in the show rates between virtual and in-person visits, the thing of note here is that our in-person visit no-show rate is 13% now, and it was just over 15% prior to the pandemic. The introduction of telepsychiatry really didn't impact our hospitalization rate, which remains essentially the same both pre, during, and post-COVID. 6 months after we introduced telepsychiatry, we did a brief patient telepsychiatry satisfaction survey, and we repeated it again last month. The survey was conducted over the course of a week, and patients who had appointments were asked to complete it. On both occasions, we had 49 valid surveys returned. As you can see, the demographics of those who participated as essentially the same at both time frames. When we look at patients' thoughts on virtual visits, we can see that at both waves, the majority of patients liked virtual visits, but the number was lower in the most recent survey. And even more surprisingly, in the recent survey, only 33% of patients preferred virtual visits compared to 2/3 in the earlier survey. When we look at the most frequent reasons that patients preferred in virtual visits, we can see that Safety and ease of getting an appointment are no longer a concern for people, but the convenience and the lack of need for transportation or parking remain important advantages. When we look at the reported disadvantages to virtual visits, we see that patients are not as concerned about their privacy during a telepsychiatry visit, but they still don't find them helpful if they're in crisis, and they find in-person visits more therapeutic and less distracting. Here are some comments that patients had from the last survey. I find it easier to connect when I am in the same room as the provider. In-person is better for therapy. Face-to-face human connection is more beneficial. And this one I think really captures all of it. It says they both serve a good purpose. Video for more maintenance like check-ins, in-person when in distress or more serious problems. So we now have telepsychiatry as part of the service, the way we do services in CPP. We've tried to integrate it in a way that promotes establishing rapport and facilitating access, but we try to remain flexible. For example, if a current patient has an in-person appointment and on the day they have childcare issues, well then we just switch to a virtual visit, so care is not interrupted. A couple of years ago we developed and implemented a texting program for relapse prevention in schizophrenia. I've discussed this a little bit before, but just to refresh, it was basically, the study involved 3 phases, and at each phase there was significant involvement from patients and providers. The third phase of the study was a randomized controlled trial involving over 40 patients, and the program design was that all the patients enrolled were sat with their provider, identified 5 early warning signs of relapse. They were then randomized to treatment as usual or the intervention. Those in the intervention received a daily text message asking about one of their symptoms of relapse, and a daily text message that was either encouraging medication adherence or an inspirational quote. If a patient endorsed a symptom, then they received a text message with a suggested coping skill that they could use, and if they reached the threshold number of symptoms, their provider was alerted and they contacted the patient within 24 hours. Although the trial was basically powered to assess for feasibility and acceptability, we did report on some clinical outcomes. We found that in the intervention group, the positive PANSS score was significantly lower at the 6-month end of the trial, and medication adherence was better in this group, especially for depot medications. While there wasn't any significant difference in the need for a higher level of care between the groups, the recovery scores of those in the intervention were higher at 3 months, and patient empowerment scores increased over time in this group. So the results of the study were encouraging. The program did meet the criteria for feasibility, acceptability and engagement, but the clinical results obviously require confirmation in a larger study, and we're currently discussing a potential collaboration with another institution who has expressed an interest in the program. Next, I want to talk about recovery-oriented services. So what is recovery? Well, there are a number of definitions out there, and sometimes there's a distinction made between personal recovery and clinical recovery. I like this one by SAMHSA, which described recovery as a process of change where over time individuals improve their health and well-being, live a self-directed life, strive to reach their full potential. And I think this allows for both personal and clinical recovery. A literature review by Subandi found that there are 7 principles that should be guidelines that we are used if we're implementing research-oriented services. Cultivating hope is the main principle and is central to recovery. The other 6 principles, such as recognizing the uniqueness of an individual and their cultural context, or facilitating social supports, are all important in the delivery of recovery-oriented services. Within recovery-oriented services, there's an emphasis on a person's own goals and aspirations, and we as psychiatrists and therapists frame our interventions in a way that makes the patient see how they're going to attain their goals. We try to keep patients feeling connected with their community and feeling that they have an identity beyond their illness. Utilizing recovery-oriented services has been shown to lead to an improvement in overall illness management, makes patients feel more hopeful and empowered, and they experience less stigma. So what are recovery-oriented practices? Well, a lot of these are things we all do on a regular basis. Providing patient-centered care, which means developing a system of care that revolves around the patient as opposed to the patient revolving around the system. Utilizing shared decision-making where appropriate. For example, in psychiatry, there are several medication options for many of the illnesses that we treat without a clear benefit of one medication over another, so we can provide the patient with options and make them feel part of the decision. Motivational interviewing is a recovery-oriented practice that, where delivered well, can make the patient attain their goals in a very empowering way. And family education, supportive employment, and peer support have all been found to improve overall outcomes. So what are the techniques that we use when we're delivering these recovery-oriented practices? Well, instilling hope, as I mentioned earlier, is a really important and essential to recovery. Focusing on the patient's strengths and looking beyond it. Within CPP, we've adopted several of these recovery-oriented practices. We have peer and vocational rehabilitation counsellors in our ACT program, and staff are trained on the development of wellness and recovery action plans. Throughout the program, our treatment plans include personalised goals that are addressed in therapy and reviewed regularly. And we have provided motivational interviewing training to staff in the past. We also track patients' recovery by administering the revised recovery assessment scale every 6 months. In 2021, we published the results of a study looking at our RAS scores over the 2-year period. So the RAS is a 24-item self-report scale with 5 response options. It was developed to measure self-reported recovery in individuals with serious mental illness, and it has an overall score and 5 subscale scores. And those are personal confidence and hope, willingness to ask for help, goal and success orientation, reliance on others, and no domination by symptoms. When we look at the overall scores, not surprisingly, we found that people who stayed in treatment longer had better scores. Of interest, we found that those with a primary diagnosis of schizophrenia had significantly higher overall scores compared to those with affective disorders. And the RAS scores increased with age but were not impacted by race or sex. When we looked at the subscale scores, some interesting findings emerged. We found that African Americans had a greater average increase in scores on the personal confidence and hope subscale, and those with schizophrenia had higher average scores than those with affective disorders in 3 of the subscales: personal confidence and hope, goal and success orientation, not dominated by symptoms. We also found that increasing age was associated with higher average scores on personal confidence and hope, reliance on others, and not dominated by symptoms. So some of our conclusions from this is that our CP patients who've lived with serious mental illness longer do better in recovery, which may be mediated by their ability to not feel controlled by their symptoms. A study by Ali found that among African Americans, positive collaborations decreased the negative effect of psychotic symptoms on recovery, and so our results suggest that the relationship African American patients had with their CPP providers may have influenced the higher scores on the personal confidence and hope subscale that we found. Next, I want to talk about lifestyle interventions. So, we all know that patients with serious mental illness have a 2- to 3-fold increased mortality rate compared to the general public, and often die 13 to 30 years earlier than their peers. 2/3 of these deaths are from natural causes, and the commonest cause of death is cardiovascular disease. We also know that there are many modifiable risk factors that have a higher prevalence in patients with serious mental illness: obesity, metabolic syndrome, smoking, diabetes, dyslipidemia, hypertension. While medications and symptoms form part of the risk for obesity in those with serious mental illness, lifestyle factors also contribute significantly. Smoking has a high prevalence amongst those with serious mental illness. As we know, up to 90% of our patients with schizophrenia smoke, and while those with depression and anxiety, 40 to 50% of them smoke. And we also know that 40% of smoking-related deaths in the year occur with those who have psychiatric or substance history. But the cardiovascular risk factor can be decreased in those with serious mental illness. Gail Dormont's group published a paper in 2020 where they carried out an 18-month-long intervention in 4 psychiatric outpatient clinics. And they targeted cardiovascular risk factors through weekly or bi-weekly educational and counselling sessions with a health counsellor, by collaborating with physicians to manage risk factors, and by coordinating with a mental health specialist to help patients attain their health goals. And at the end of the intervention, they found that the Framingham risk score had decreased by 12.7% in the intervention group. In CPP, we are aware that a lot of our patients are at a higher risk of cardiovascular disease. And the ACE study, we found that 95% had below average fitness levels, and those with lower fitness levels had a higher BMI and higher percentage body fat. We also found that females and African Americans had lower fitness levels than males and non-African Americans. A number of years ago, we introduced a health and wellness initiative where we provided health-related information to patients. It was a 12-month initiative. We focused on healthy eating, exercise, smoking cessation, and at the end of the year, we administered a survey to patients to try and assess the impact the initiative had on their behaviour. We found that 90% reported making some behavioural change, and 10 out of the 32 who reviewed information on smoking cessation reported that they stopped smoking. So the study results suggest that even providing information on cardiovascular risk factors and suggestions on how to manage them may be of help. After that, we focused more specifically on a couple of areas with a particular emphasis on smoking cessation. We modified our templates to make sure we always asked about smoking status. We had smoking cessation groups and presented patients with certificates if they stopped smoking. And more recently, we've been involved in Gail Dormont's impact study. The impact study involves specific training for therapists and psychiatrists on motivational interviewing skills to address smoking cessation in the seriously mentally ill. While the results of that are still being analysed, we continue to ask patients about their smoking status. We continue to encourage them to stop smoking. We continue to prescribe smoking cessation medications. And we've included a session on smoking in the seriously mentally ill population in our Community Psychiatry PGY3 seminar series. As well as smoking cessation, we encourage all our patients to include in their treatment plans a goal that is related to exercise. And we also work with them to ensure that they have a primary care physician and attend their appointments. Finally, I want to talk very briefly about collaborative care. So collaborative care is a form of integrated care that has been around for over 2 decades. It's a team-based service embedded in primary care where on-site behavioural health specialists coordinate with the primary care physician and consulting psychiatrist to treat patients. There are 5 elements to collaborative care. The care is patient-centred and given to a defined patient population. The treatment is evidence-based, and the treatment outcomes are assessed on a regular basis. And providers are held accountable for the quality and cost of the care. As up to 60% of patients with psychiatric illness are only ever seen by their primary care doctor, collaborative care has the potential to increase access to care for these patients, and it has been shown to improve depression outcomes in those with racial and ethnic minorities. Therefore, collaborative care is an important service delivery model which is likely to increase and become more widespread in the coming years. To wrap up, I just want to review that mental health, e-mental health services can improve access to care, but we need to monitor the quality and effectiveness of the care delivered, especially those in online programs. Recovery-oriented services can improve overall well-being and decrease stigma, and instilling hope is a key component. I think we heard that word several times today when we met with our patient. Lifestyle interventions can improve overall health and decrease the mortality rate amongst those with serious mental illness. And collaborative care improves access and treatment outcomes for patients who are seen in primary care. Lastly, I'd like to thank all the patients and staff of CPP and my research collaborators, Michelle Ybarra, Gail Domit, Ramin Mochabai, who is involved in any statistic I ever do, and all the others who have helped me over the years. Thank you.
Thank you, Dr. Cullen. That was outstanding. I want to focus on the recovery-oriented services issue, which is something that I've heard about, thought about a little bit, but I'm not sure I ever fully grasped it as well as I think I maybe do today, which is to say, what strikes me is that I'm wondering whether recovery-oriented services is really essentially a way of people asking for what we always more or less do here, which is to say, let's not just focus on disease, let's focus on disease and the whole person as well. And you sort of alluded to it, that you said as you were going through it, you were saying, well, it's a lot of the things we already do. I guess, first of all, do you agree with that characterization? Second of all, are there aspects of recovery that are really different from what we typically do and are kind of something to add on to what the kind of care we provide ordinarily?
So I think the word recovery got a bad name early on. So I think in the early 1990s, it was sort of what we call a consumer movement, and it was seen as recovery, people not respecting patients. Right. All you do is give medications. And and I think a lot of psychiatrists and therapists, we kind of shied away a little bit from it because it was getting this sort of bad press. But I think when you think about it, right, recovery is really thinking of the whole person and trying to help them achieve, obviously help the illness, but beyond that, it's never enough to treat the illness. We have to think and consider everything else and the context in which this patient is coming to us. And so I think now there's more of an openness to considering it. The other place where there's maybe some controversy related to it is in the whole area of involuntary commitment, and that can be, if you believe in involuntary commitment, are you really recovery-oriented? I personally don't find a conflict between that, because at each time, the patient is central, and helping the patient and getting the job done for the patient is what's most important. Sometimes that means we have to step in, but that doesn't mean it's not recovery-oriented. You're not helping the patient and not having them feel empowered. So,
makes perfect sense. Makes perfect sense to me. Other thoughts, questions out there? Yes, Dr. Prince.
Thanks so much, Dr. Cullen. It was great to hear also about collaborative care. As a CL doctor, there's lots of interest in that. I was wondering, has there ever been consideration for sort of the inverse of integrating a primary care doctor into CPP?
Yes. So Liz was asking about the reverse of collaborative care, which is based in primary care, but having primary care in CPP. I think that they call that reverse integration. I think that's the term that's used. And yes, I think it all comes down to costs, because one of the sayings I have is that every person who comes to CPP needs a primary care physician. Not every person who goes to see their primary care needs a psychiatrist or needs psychiatric care. It would be wonderful. We are kind of blessed here because we have access to primary care and are able to do that. So in this institution, a lot of our patients are already engaged in primary care here, and we have an ability to communicate with the primary care physicians. EPIC has really improved that, and I can't tell you the number of times I've been so grateful for EPIC. Not always, but in this particular regard, to be able to reach out to someone's primary care doctor to talk about them. But outside of here, I think that is, and there are some places that are trying, other states that do that, but I think it comes down to, like many things, cost.
Other questions? Dr. Gilbert.
Follow up on that. Sometimes we think of
Yeah, I mean, I think as Dr. Potash said at the beginning, I trained in, in general medicine first, or in general practice, which is what we call in Ireland. And I can't, the value that has been to me as a community psychiatrist is great, because I'm still now a distance away from that training, but it's, I still remember I worked as a GP. I kind of think about things in that way in medicine. So I do think that kind of background is helpful in a community psychiatry. I think for all of us who work in community psychiatry, we're generalists, but the other piece about it is that a lot of the, both the therapists and the psychiatrists have really got a strong social conscience and really want to provide care to this particular population. And so there's, beyond kind of the general stuff we do, there's that sort of commitment to community that is important for us.
Thanks. Other folks? Dr. Swartz.
Dr. Cullen, that was wonderful. I am, of course, intrigued by the fact that patients with affective disorders were not having the same outcome for recovery.
Yes.
So, just to save face, did they start at the same spot?
I was wondering if someone would be, yes. So we did struggle with this. So this was, started 2 years. It was just cross-section, whoever was here at the beginning of it and at the end, right?
Want to repeat the question?
Oh,
for
I'm
folks
sorry.
in
So
Zoom land.
Yes. So Karen was asking about the recovery scores for patients with affective disorder and why that seemed to lag behind those with other conditions. So everybody started the study, or we started looking. It was retrospective, looking at the scores. So you had a mix there of people who had just come into the program, people who've been in the program for a while, and we just moved on 2 years. When we were trying to make sense of this, we wondered if, two things. We wondered if the expectations for recovery may have been different in the two groups. And we also thought, well, if patients, the hopefulness subscale, the piece of that may be less, that some of the symptoms of depression that may be affecting it. The other part that we didn't have really the numbers to go back in is if we separated out major depression and bipolar, would we have found something different? Because I think what they've found in other studies is bipolar illness, the higher recovery scores as well. So it's not, yes, more work needs to be done.
That was surprising. I guess one other thought on that is it possible that your team has more expertise in treating schizophrenia than treating affective disorder? What percentage of the patients have schizophrenia?
So in our general clinic, 30% of the patients with schizophrenia and 2/3. So no, I wouldn't say, I think we...
Dr. Franklin.
Right, so the question that Cleo had was that if recovery scores aren't improving, how are we addressing that in clinic? So we administer this every 6 months, which it coincides with the time we do their treatment plans. Obviously, I'd like to think we're thinking about these things in between time, but every 6 months is a time for us to really see, okay, well, this was low 6 months ago and it's still low. And so as we develop those treatment plans, we're talking about ways that we can improve their recovery. What are the things that are not helping them move forward? And that's kind of the discussion. Those treatment plans are usually done in the context of a multidisciplinary team where they're sitting with the psychiatrist and the therapist and the patient. And so everyone's sort of putting their heads together to try and think about this.
Great. Dr. Tobolowsky.
Has the data gotten down to that level in terms of other specific diagnoses where in-person visits have been shown to be more effective in telemedicine?
Yeah, I don't know if there's that much out there that shows more effective in terms of, the telepsychiatry is more effective, but I think they've certainly found studies where for PTSD, for some anxiety disorders, that it can be equivalent in its effectiveness. But again, it's, even when you look at the CBT stuff online and they talk about guided CBT and non-guided, what they find is that if people have very mild depression, it doesn't really matter. But if you've got moderate or severe depression, you need the guided. It's not enough to just sit up in your computer and do an online CBT course. That's not going to get you where you need to be.
Mm-hmm. Other folks? Dr. Lipsy.
Are there any studies that, I'm sure there's some, but are there any studies you can tell us about that address how well or how different the inpatient visits and telepsychiatry visits are able to transmit or detect mental states and emotional expression and even simple things like tears welling up in someone's eyes? I mean, there's bad film and there's good film. There are things that you can do better at a distance and things you can do better in person. But I'm wondering, is there any basic science study
Yeah.
what you can transmit with these kinds of images in the way we usually do it?
You know, I haven't looked at particularly inpatient delivery of services inpatient. If you remember, when we, when COVID hit here, we kind of backed away from doing it. We would do our rounds, through Zoom, but the in-person patient thing still happened. Although I will say that as time has gone on, we have on occasion used virtual rounds for, if an attending is unwell and can't be there, and technically you're allowed to do visits virtually inpatient once every 3 days. And so we've utilized that. I don't think, I was talking to someone about this actually recently, and I think their experience of it is that they didn't really like it. It was handy in an emergency if they were well enough to do rounds that they could do them through telepsychiatry, but it wasn't a very satisfying experience. But I don't have, information specifically on what you're asking about.
I thought it was interesting to see the results of your survey with your patients, and somewhat reassuring to see that patients often felt like telepsychiatry was not as therapeutic as in person, because I think many of us have that feeling.
Right, yeah, and I think, when we first did this survey, it was 6 months after we were still in the middle of the pandemic, and I'm sure part of the reason people preferred the virtual visits, it just was safer, and they didn't have to come out. But now when we're in a different sort of era, when people have choices about it and how they feel about it, the majority now prefer in-person visits.
Yeah, that's interesting.
And, I think that's, I certainly prefer them, but I do see the value of having the option, for sure.
Yeah, makes sense. Well, thank you for a terrific round. Really appreciate it.